TNT Open Mind Insights brings you powerful, authentic conversations, illuminating the path to better mental health care for all.
Dustin, good to see you. Thanks for joining me and talking to me a little bit about your views on mental health. Um, so I was wondering if you could just start off just telling me a little bit about you, your background, what you do in medicine, where you practice.
Yeah, sure. Thanks for allowing me to be here, Robert.
Yeah,
Always a pleasure spending time with you and the crew.
yeah.
Um, so my background is internal medicine, psychiatry, and addiction medicine. Did the 5-year combined training at Tulane. Great experience, a lot of good training down there. And
So
then
5 year combined training, meaning during those 5 years you did some psychiatry, you did some internal medicine, and when you were done, presto, you became an internist and also a psychiatrist.
that's exactly right.
Awesome,
Yeah.
awesome. Who would? That's amazing. You do something like that.
I saw an opportunity and I learned about it through a particular organization. I was like, that's what I want to be. I want to be the pent ultimate physician who can take care of anything, anywhere, and anybody.
That's good.
So
And then you added addiction training on after that.
that's correct. So when I graduated from Tulane, came back to Fort Worth where I went to medical school, and the institution that I came back to and am currently in didn't really have any sort of addiction footprint at all. And I
Mm.
saw a vacuum and I saw an opportunity to put a lot of my interest and education to fill that vacuum and did some research. And we have an addiction service line, and that allowed me to compile the hours to do the addiction medicine pathway.
Mhm.
So I sat for that board and have been pretty active in addiction ever since.
Wow. So that keeps you busy. Do you still practice internal medicine?
Oh, yeah,
Yeah.
absolutely.
And you're also a psychiatry residency director and vice chair of education in your department, correct?
That's correct.
What's that like?
It's a lot of work, but it is the fruits of that labor are so big and bountiful that I'm very fortunate to be in that position.
Uh-huh.
I've been in it for 3 years today, and it gives me a unique perspective on what the trainees, the residents, what how they come in, and gives me really boots on the ground view of what they need to know when they get done training.
Yeah.
The vice chair piece lets me have a little bit of perspective on what my faculty know and where their knowledge gaps are. But that also gives me an idea about our nurse practitioners and PAs. Gives me an opportunity to, just kind of feel out where they're struggling and be able to offer some support to fill some of those gaps as well.
So you work with nurse practitioners and PAs as well in the capacity of being a vice chair of education.
That's correct. And we have a postgraduate training program that's accredited for nurse practitioners and PAs who, once they get done with school, they can come in and get some extra education in psychiatry specifically.
That sounds pretty cool. It really in line with a multidisciplinary sort of team-based setting, right?
Absolutely.
Yeah.
Absolutely. I mean, there's a huge shortage in mental health providers, and we're doing everything that we can in Texas to try to fill that gap any way we can with good, competent clinicians using pretty rigorous standards and assessments.
So Texas, let me tell me a little bit about what it's like in Texas. I'm not talking about the restaurants and stuff. I mean mental health care delivery. What are some strengths maybe that you're finding in Texas and maybe areas that could use some help in that state?
Yeah, sure. Texas, you know, is very patient autonomy forward
Yeah.
in most things. When it comes to mental health, very, very much so.
Yeah.
And so, if you have somebody with an acutely ill, psychotic disorder or disease,
Hmm.
it's very challenging to really try to get them the care that they need.
Okay.
Some areas that could lend itself to some improvement is education to the judicial system, saying, "Hey, these are physicians. They have good knowledge of what really needs to happen in this patient's care.
Yeah.
Let us give us a little bit more leeway to do that." Um, One area that they've been very supportive
Hmm.
has been expansion of access for behavioral health. That comes in a couple of forms.
Okay.
One is they're very if you present them with a plan to
Hmm.
grow a residency or start a residency for psychiatry, they're like, hey, yeah, go for it. Child adolescent being a big target. Um, and so they're pretty, pretty supportive from a financial standpoint.
Wow. So if someone says, I want to grow my residency by 20%, they'll work with the academic institution to help grow that program and expand workforce.
That's exactly right. Absolutely.
Not many
And
states do that.
not many do, no,
That's
and
good.
we're in a fortunate position that that Texas does. I think some of the things that led to some of that, support has
Yeah.
been some of the mass shootings that occur in Texas over the last several years,
Yeah.
and they really view that as a mental health challenge that really needs to be addressed as early as possible, and so they're putting a lot of resources behind that.
Well, I mean, generally speaking, it seems like someone would be pretty troubled emotionally without even giving a diagnosis if they're going to go into a school and shoot people.
Indeed.
And I think that that makes a lot of sense for a mental health system to support kids who may be struggling in order to prevent that kind of badness from happening, because that's just a huge trauma for a town, a county, a state,
Yeah.
our country, when that kind of thing happens. So that's really good to hear.
Absolutely. And not only are they putting a lot of resources behind, um, clinician development and training for residencies and fellows,
Yeah.
but also they're putting more clinicians, advanced practice providers, social workers, counselors into school settings. So they're
Hmm.
paying for institutions to develop those individuals and put them in specifically school-based settings to
Wow.
help prevent what you just mentioned.
No, that's great. That's great. It's nice to see that. I know the state of California, gosh, 20 years ago, probably came up with what's called the Mental Health Services Act, where they created a funding source. Everyone over making over $1 million got taxed or is getting taxed 1% above that amount. And that money goes to the now Behavioral Health Services Act to help support infrastructure and programs in the area of mental health and homelessness.
Oh,
And so it's neat to see that where you're at in Texas, something similar is happening. They're able to find the money somehow and support growth and expansion, because it's certainly needed. I think pretty much everywhere, most everywhere in this country for sure. So
absolutely.
yeah, well
Absolutely.
that's good. It sounds like you're pretty involved in it regionally as well from a leadership standpoint. Can you tell me a little bit about how you view leadership and the importance of leadership when it comes to the development of new physicians and clinicians? And what is your stance on that and your involvement as a leader nationally as well?
So, as you mentioned, leadership takes forms in different settings,
Yeah.
locally, regionally, and nationally. I really try to be visible locally. So, I
Okay.
want my residents and my fellow faculty to see that I'm on the front line too.
Yeah.
Like I'm going into the clinics, I'm going to the consult service, I'm going to inpatient settings,
Yeah.
and I'm with you. My sleeves are rolled up, and I'm ready to do the work. And I'm not going to be down about it. I'm going to be excited about it because I get to see patients. I'm getting out of my office, getting off of Zoom land, and I'm going in and I'm stomping out disease.
Yeah.
And I think it's important for them to see that because that will help lend itself to less, fatigue, less burnout from residents, because they get excited when they see somebody excited to take care of patients. And I try to be an example for that. Regionally, um, from a leadership perspective, Texas is new to the substance use treatment game, and so that's where I found again locally I found a vacuum there, and regionally across the state I'm finding a vacuum there. So I've
Uh,
joined up with other um, universities within Texas
uh,
to help lead the improved access, improved education for substance use disorders. So
mm. How do you do that? Do you work with policymakers, legislators, regionally and statewide? Is that to, because I can imagine some of them don't quite understand what it's like. Because guess what? Many of them, most of them, almost all of them, probably are not. They're not seeing patients. They don't know the angst and the intricacies and the complexities associated with substance use disorders. Do you help them understand?
to the best I can.
Yeah,
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 Robert. So I'm part of an organization that's funded by a state grant and gets delivered to a lot of the universities. And
yeah.
it's called Be Well Texas, and the name of the grant is SHOUT, Supporting Hospital Opiate Use Treatment.
Oh, wow.
And it's an education-only grant. And it buys a little bit of time for myself and my team to spread the knowledge in our institution, but also using the ECHO format,
Yeah.
spread the knowledge to other places that may either not have their own addiction service or maybe trying to develop one or whatever.
Yeah.
And so we get to harness that mechanism to implement substance use services. And then once a year, we come together all in person
Mm.
at a Texas Substance Use Symposium and get together with policymakers, advocacy groups, and seeing, where are we missing the mark? Where
Yeah.
are we nailing them? But also where is there opportunity to be had?
Wow, that's pretty cool. It sounds like you're shaping the way medicine and substance use um, delivery is taking place. And you mentioned that they're a little behind, maybe,
A little
and
bit.
that happens. Some states are a little ahead, some are a little behind. But I see it as it sounds like you see it as an opportunity to affect kind of more long term and hopefully sustained change, right?
Absolutely. One case in it, for example, harm reduction.
Hmm.
There's a lot of states that have, needle exchange, fentanyl test strips, et cetera,
Yeah.
that freely give out to the patients.
Uh huh.
We don't have that right now in Texas. However, they're in legislative session now, and there's actually a bill proposed, and I
Yeah.
think is garnering support to actually offer some fentanyl test strips because we did see a huge spike in overdoses primarily due to fentanyl in the drug supply.
Wow.
And I think lawmakers are slowly starting to see like, oh, large part of my constituents are dying,
Yeah.
and so we should probably do something to not let that happen.
Well, I imagine it takes a little while to change culture, right? And that's kind of what you're doing. You're leading that in your state with your colleagues to change the way people see healthcare delivery, and that includes substance use disorders, right?
Absolutely,
Yeah.
it very much is a culture change, and that has to happen locally, and then it spreads,
Yeah.
and it's got to. There's a couple of ways to do that: education, research, but really getting to somebody's heart and soul of seeing patients
Mhm.
and their constituents through a destigmatizing lens.
Yeah.
That's where you see a lot of the administrators start to say, "Oh, well, that does make sense."
Yeah. It's hard to do, though, I imagine. So,
It has been challenging,
but
but rewarding.
it's nice to hear that you're doing that. And then talk to me a little bit about, and I know some of the work you've done nationally, but if you could talk a little bit about sort of, where you see medical education going, and also the work that you're doing and have been doing nationally in this space as well.
Yeah, absolutely. Um, there's a huge healthcare, especially mental health care shortage
Yeah.
in terms of workforce. A huge gap. We're continuing to dig the hole. There's more people leaving the field than there are coming in, and that we're going to continue to dig that hole to the year 2036.
Yeah.
So how can we fill that? A couple of ways. Um, Educating nurse practitioners and PAs as much as possible,
Yeah.
shortening the length of time for medical students to become doctors and for doctors to become psychiatrists. Um, but also, there's a I think a changing theme on how we measure education. Historically, it's been time and training. Nurse practitioners need X amount of hours. PAs need X amount of hours. Physicians need X amount of years.
Yeah.
We're really starting to change the conversation to what competencies can they demonstrate. So competency-based medical education, I think, is the way that we're going to be assessing education going forward, and then hopefully reduce the amount of time, shorten the length of training, and start filling that gap a little bit quicker.
Yeah. Well, training to become a psychiatrist is, how many years does it take?
It's
It's a lot
four
of
years of
years.
school, 4 years of psychiatry education, and then 1, 2, 3 years of fellowship.
It's all coming back now. Yeah. So it's many years of training,
Many
12
years.
years or so.
Hmm.
And if there's a way to consolidate that, maybe, and I know there's been a lot of talk about that nationally, but that would be, I think, one way to, as you said, close the gap, expand access to workforce where it's needed the most. So we'll see where things go over the next couple of years in that respect. I know you do a lot of work. You've been involved with the Association of Medicine and Psychiatry, which I'm biased. I'm a part of the organization as well, but it's just a very unique association and kind of combining folks who have a strong interest in mental health and a strong interest in training in general medicine, like internal medicine or family medicine or pediatrics, for example, and showing the importance of combining those two. Can you talk a little bit about that importance and maybe how it interplays with the association?
Absolutely. So the association is a great place for folks who are interested in learning how to merge the treatment of mental health and physical conditions, not just for those who are doing combined training, but a lot of my categorical psychiatry residents, they see patients who also have a lot of comorbid medical diseases.
Yeah,
And every single year, I have at least one or two residents present posters at the Association of Medicine and Psychiatry.
yeah, that's pretty cool.
It's absolutely cool.
Yeah,
And it not only is it an opportunity for trainees to showcase the things that they've seen and are working on, but it also, I think, is a great brain trust
mm,
because a lot of the folks at AMP are also part of other organizations and they can help these other organizations continue to further integrate the treatment of mental health and physical health so we can shorten those education years and training years and address the healthcare gaps that we see. Even though you may not be combined training, that doesn't mean you can't recognize hypertension or
mm.
diabetes and maybe start something and get them onto the next person to help close the healthcare gap for that individual.
Yeah, no, that makes sense. It's neat to hear all that you're doing again locally, regionally, nationally when it comes to innovative, out of the box, hopefully really effective thinking and planning. Question for you: you're a residency training director, so you train folks early in their career. Do you think it's important for physicians in particular or residents um, to also be leaders and learn how to lead a little bit? It doesn't have to be national leadership or even regional, but to somehow lead, to give back in some way. Are your residents seeing that? Do they see the importance of that?
Most are.
Most are.
Some and the few that aren't immediately see the value by by the end of their second year, beginning of their third year.
Okay.
And it really comes in the form of, for us, there's a couple of programs that once a patient gets discharged, there's a venue for them to come back and share their experience
Yeah.
with the social workers, the treatment team, and sometimes there's really critical feedback during those sessions. And the residents hear that feedback, are able to implement that, and then teach the younger ones and lead the younger ones to say, hey, when you have this kind of patient, maybe ask these questions this way,
Yeah.
not so much this way. And so it really helps them to develop leadership skills, interview skills, because as a physician, they're going to be leading treatment teams.
Yeah.
They're going to be driving the conversation of care with the families. And so I think it's a critical skill that these trainees need to have by the time they graduate.
Yeah. And teaching too, if they kind of see one, do one, teach one, that's what
Right.
they teach you in medical school, right? So
Yep.
you see something, you're like, oh, that makes sense. And then you're going to do it yourself, might feel a little uncomfortable doing that. And then you're going to teach someone how to do it.
Right.
So, um, and I also know that you and I work together on this. I know that you spend a lot of your time teaching non-behavioral health specialists, like primary care docs and primary care clinicians, how to recognize depression, how to recognize anxiety. How in the world do you deal with substance use disorders? They don't teach that in most residency programs. They just don't. So, I mean, what drives you to do that? Is it fulfilling work for you to train these folks who are in the front lines? You mentioned that earlier. They're in the front lines. They just didn't get the training on how to do that.
Right. It's twofold. One, in my institution, great family medicine program, they are hungry. They want that knowledge
Oh,
because
that's
they
great.
want to go out
Yeah.
and be able to do anything anywhere.
Yeah.
So I love that. They're hungry for it. The other piece is as we're thinking about, changing culture, changing attitudes, that's what drives me is changing the way somebody thinks.
Yeah.
Because I'll give you just a brief example. A colleague, we were in med school together. Um, she stayed behind to do a PhD. I went to residency. When I came back, we were working nights in the psych ER, and she went to see a patient. Came back, and I was like, "Oh, what was the patient about?" She said, "Oh, just a druggie." And I'm like, "Oh, well, that's unusual. I wouldn't have, thought of you as somebody who would use stigmatizing language because She is an expert in the field of LGBTQ plus community. She leads transgender focus groups. I mean,
Yeah,
she's well versed and can recognize a stigmatized population.
sure.
But she started using that language, and I'm like, wow. And so I, the next day, pulled her aside. I was like, hey, can we talk about, this conversation we had last night? Um, the nurses hear things like that. The techs hear things like that. Learners hear things like that. We're really not doing anybody any good by continuing to use that kind of
Not a
language.
great example.
Exactly. And when I, talked to her about some modules and some resources, and then 2 weeks later she came back. She said, "I actually saw what you were talking about, and thank you. I
Wow,
had no idea that I was coming across that way. So thanks for pointing that out." So being
wow.
able to change somebody's thoughts or the way they approach a particular patient or population of folks, that's really um, a driver for me.
Language matters, you know, and it's almost like for many years I would hear my colleagues on rounds and stuff say, "Oh, 23-year-old schizophrenic," right?
Yeah.
Instead of a 23-year-old patient with schizophrenia.
Right.
And it's similar but very different.
Hmm.
Saying someone's a schizophrenic,
Right.
right? And or a druggie.
Right.
And I think that it takes leadership to have that conversation because it's awkward. Was it awkward for you?
Absolutely.
It was awkward.
Yeah, it was, and it's always harder to tell your friends like, I think you're doing this wrong, as opposed to somebody you don't know or somebody that you may not be all that affectionate for.
Yeah. Yeah.
So
No, that's it's important to because we're actually folks are probably going to look at you to and mirror what you're doing and how you're doing it, the languages you're using, and that's just so important. And I would say, particularly for primary care,
yeah,
right? Primary care clinicians, because again, they just didn't get that training.
right,
Psychiatrists get 4 years of training, and they have a little extra time. They're
right,
not working 80 hours a week.
sure,
You know,
sure,
and their offices have couches and water features, and sometimes those the little rakes with the
mm,
sand and it's but primary care. There are no couches. There's
nope,
no water features,
nope,
and it's a very different way to go to work and to treat patients,
yeah,
often with limited resources as well. And I know you spent some time again working nationally with doing this type of training.
hmm
Um, what would you say is if you were to pick one thing that's really important for them to know, whether it's in psychiatry or substance use, either one or both? What would that one thing be? If you could change one thing with how they're learning or what they're learning, what would that be?
I think for the primary care folks, you have to get buy-in. If you're wanting somebody to, say you have somebody with diabetes and hypertension and hyperlipidemia, like you have to change behavior.
Hmm.
Um, and in order to get buy-in, you have to use the language becomes important.
Yeah,
Um, and being motivating and following and keeping track or keeping log somehow of the activity and celebrating the wins
mm,
and seeing where the opportunities are at each visit. Um, because the whole goal is just move the needle a little bit each visit.
yeah,
And so, for primary care folks, I would just say, you know, identify the things that you can change in that 15, 8, 10-minute session, and just move the needle a little bit and then get to the next point, get to the next lesson.
Do you think they're okay with moving the needle just a little bit? Because what I found is a lot of times physicians, I'm going to throw myself in there too. I don't want to just move the needle. I want the whole needle to
Right,
go where it's supposed to go.
right.
Intuitively, I know that it's hard to do that.
Yeah.
But do you find that with some of your colleagues where they kind of want to get it all done? They want to fix that glucose level and make it normal, right? They want to fix it. I call them fixers. Sometimes physicians want to be fixers instead of co-managing, co-working, right, with the patient. Do you find the same? Is it just me? Do you find that too a little bit?
Oh,
Yeah.
all the time,
Okay.
all the time. Like I hear that not infrequently. Why their blood pressure was great last time, but now it's terrible. What happened?
Yeah.
Or the sugar. And There's a quote that comes to mind when I was in a grand rounds, and the quote is, the greatest accumulation of change doesn't happen in one fell swoop. It is the incremental accumulation over time of small intervals.
Yeah.
So if you want to make a huge change, you're not going to get there by making a big swing. It is the accumulation of incremental improvement over time that creates the biggest effect.
Yeah.
And so whenever I hear that, I try to remind them like, you're going to have this person for a long time. And if you're in training, you may have this person for 3 years. Don't
Yeah.
focus on this one.
Yeah.
Focus on the next one and the next one.
Yeah. Yeah. No, I mean, I think that's one of the things we see the most. As you know, I do a lot of training in what I call primary care psychiatry. So we work on training primary care clinicians on understanding the basics of behavioral health. And what I hear from them is this is too much, or I don't have time for this,
Right.
or I don't have time to open up that Pandora's box, or I can't see my patient cry because if the patient's crying, I'm going to be late for the next patient.
Right.
And it all comes down to lack of resources, limited time, physical time, right?
Yeah.
If I open up that and they say that I hear the Pandora's box, I hear it all the time. It doesn't work, right? So what do you say to that? How do you counter that? Yeah, the
Um,
Pandora's
the
box.
Pandora's
Yeah,
box. I would counter that by saying you can open it. You don't have to address everything that comes out in that one session. You say, all right, I'm gonna ask you this question, and you're gonna have a lot of feelings that come out.
yeah,
Let's talk about one feeling or one thought or one issue that comes out.
okay.
And then when you leave, write them all down, and let's use that as a footprint to drive care going forward.
And you're kind of focusing on the thought or the feeling that's most important to them,
Exactly.
not what's the most important to you.
Exactly.
Yeah,
Indeed.
yeah, no, that makes a lot of sense. And in that way, sort of empowering the patient, I think, as well, right?
Right. Exactly. Because they're interested in telling you what they want to work on.
Yeah,
They're really not interested in hearing what you think that they need to
yeah,
work on.
yeah, yeah. No, that makes a lot of sense. One last question for you.
Yeah.
If you were to give one piece of advice to folks going to the doctor, I don't like going to the doctor's office, by the way, I just
You know,
don't. But if you had to give one piece of advice to people, to patients going to their doctor, what's one piece of advice you'd give it to patients?
I would say have trust and be honest.
Yeah,
Because you're going to the doctor to help ensure that you're in health, try to get in better health, or change because you're not in good health,
mhm,
right? And so you have to trust your doctor, your nurse practitioner, or your PA enough to say, hey, here are my issues, I'm being vulnerable. But then you have to be willing to be honest when you do have shortcomings,
yeah,
and when you have big wins, be honest about that as well.
yeah.
And so have a great relationship with that person because over time, as you make those incremental changes, that's how you're going to see the biggest improvement.
So try and build the relationship, really try and develop that relationship, that trust, as you said, with the provider, which sometimes can take a few visits,
It
right?
could take a little time.
It may not happen on the first visit, so
Absolutely not.
which is kind of normal.
Yeah.
So, so Dustin, how do people get a hold of you if after watching this they want to explore some of these themes a little further?
Yeah, I welcome, any questions, comments. I'm on LinkedIn. I'm at the University of North Texas Health Science Center in Fort Worth. My hospital is John Peter Smith Hospital in Fort Worth. We're the county hospital.
Yeah,
And so, if they want to reach out to me any one of those ways, feel free. I'm happy to connect.
awesome, awesome. Dustin, thanks for taking the time to talk with me and sharing your insights. I appreciate it.
Absolutely. It's my pleasure, Robert.
Thank you.